project or subsequent projects? That is the question that has effectively been addressed in Malawi through partnerships between civil society organizations, NGOs, UN agencies, and the government of Malawi. This presentation looks at how practice influences policy, how then policy, effective policy change, supports practice and strengthens integration and linkages, as we're talking about here, and therefore the title, Policy to Practice. I was tempted to go back to policy to practice to policy, because essentially that's what has happened in Malawi. So I'll have just 5 slides. The first one is the agent of change. What stimulated the change in Malawi? And then what gap did this stimulant recognize that needed to be addressed so that the policy change takes place? And then the cycle that has occurred in Malawi that has resulted in the change. And from the words of the people in Malawi, what key lessons can we take home? The Integra initiative, I think for those of you who have been to the booths, you've seen Integra, and there's a lot that you can pick from the booth, from our colleagues that are displaying materials there. This is a 5-year multi-country operations research project that is a collaboration between IPPF, London School of Hygiene and Tropical Medicine, Population Council, and the respective ministries of health in the 3 countries of Kenya, Malawi, and Swaziland. It's been running since 2008 to December this year. The main components of this project, of this initiative, look at strengthening integrated service delivery through building capacity in terms of provider capacity, in terms of the space, infrastructure, and supportive environment. Providing evidence on socioeconomic benefits of integration through various arms of research that are looking at issues to do with stigma, effect of integration on unplanned pregnancies, effect on cost efficiency, as well as quality of care. And in turn, the initiative aims to inform policy to be able to strengthen linkages. While Integra started in Malawi through strengthening the capacity of the member association in Malawi, that's Family Planning Association of Malawi, which is a member association of IPPF, through infrastructure improvement, capacity building for staff, strengthening commodity supplies, because one of the inherent weaknesses or dangers to integration is commodity stockouts. When you create demand that you cannot meet, then it backfires on the integration agenda. And the project focused on strengthening that. As this was happening, one of the key things that was realized was that in terms of integrating services and expanding the range of services within these integrated facilities, there was a policy gap. There were guidelines that were actually negating the gains that were being made. For instance, at that point in time, to integrate HIV counseling and testing into family planning was a bit of a challenge, because the guidelines was for provision of vertical VCT services and family planning services. To integrate ART into the SRH program required additional personnel, because the service providers, that were the nurses and the clinical officers, could not initiate ART. So this was going to necessitate a policy change to accommodate this particular service by the available staff cadre. So this was happening as an anecdotal piece of evidence. Providers were actually indicating that we are not able to do this because of this guideline. The good thing was that at the inception, the Integra took on board the Ministry of Health, and in the 3 facilities that Family Planning Association of Malawi was implementing the project, the district AIDS coordinators, the reproductive health coordinators always participated in the quarterly review meetings of the family of the project, and therefore understood the issues that were arising from the vertical programming that was taking place at the country level and at the district level. As a result of that, IPPF, the UN agencies, and I'm glad to see UNFPA, WHO, and others here, came together with the Ministry of Health in Malawi to conduct the rapid assessment. And I'm not going into detail in rapid assessment because that's what John has been dealing with. And conducted a rapid assessment in Malawi in 2010. And from John's presentation, I think a lot has been said. But critically for Malawi, at policy level, the RH and HIV policies had gaps. They were not speaking to each other. In terms of program, there was vertical planning, vertical implementation, and more essentially, monitoring. The supportive supervision, and service providers identified gaps among their supervisors, where there was a service provider that had benefited from training on integrated services, but the supervisors were uncomfortable in supervision because the RH supervisor was not comfortable with the HIV issues and vice versa. The human resources for health were in a way encouraging integration by default, because at the facility level there was a shortage of service providers, and this shortage then meant that the available service providers had by no choice to provide both HIV and SRH services because that was the need of their client. For instance, from the policy documents in Malawi, the Ministry of Health was reporting vacant positions, which was a staff shortage of 24.5% and 67.5% of the clinical officers and the nurses respectively. And these are the critical cadre of staff that provide services from level 1 to level 4 services. The other thing that is critical in terms of finance is in terms of financing. And this was talked about at the plenary today. In Malawi, during the rapid assessment, actually some of the partners and the managers called it the color of money. The HIV money is blue, the sexual reproductive money is yellow, you know, the malaria money is, I don't know, is it indigo or green? Some color. So every donor has their own outputs that they want and has specific activities that their money has to be implemented to be used on. And that was a big barrier to integration. The other thing is training curricula. That, for instance, the College of Medicine in Malawi is churning out the clinical officers and the nurses with a vertical mindset. They are going to work in the maternity, they are going to work in MCH, and they are going to work here and there. And that's the mindset that they have. So the pre-service training in itself is very vertical. But then the challenge is in-service training. Again, it's vertical. We pick people 1 week to train on VCT. The next week is update on family planning. So in their mindsets, they're still very vertical. So those are the challenges that, even though the Integra had realized this was there, the necessity of the rapid assessment was that it was going to quantify this, identify key areas where actions would be taken, and it brought together all the stakeholders, the ministries, the relevant ministries in government, the donor agencies, the training institutions, and the civil society. As a result of this, then Malawi moved on. And this is what we're calling the cycle that has happened in Malawi. At the beginning, there was Integra, which aimed at providing integrated sexual reproductive health and HIV services. When we were starting, the Family Planning Association of Malawi provided 5 different services. Most of them are reproductive health. There were 3 reproductive health services and 2 HIV services, which were VCT at that time and treatment for opportunistic infections. But as we speak, as a result of what has gone on, they provide 12 different services. So expanding the range of services and, more importantly, ensuring commodity security. As a result of that, the rapid assessment was undertaken. And the key recommendations of the rapid assessment was there was need to harmonize sexual reproductive health and HIV policies. There was need to improve coordination, joint planning, joint monitoring between the reproductive health and HIV sectors, and capacity building for the service providers, and critically for the supervisors to be able to provide supportive supervision. And because the approach now was one that brought together most of the stakeholders, and the leadership was from the Minister of Health, and I'm glad that the Minister of Health is represented here from Malawi, then the leadership took an opportunity which then presented itself in leveraging and scaling up what was happening. The Family Planning Association of Malawi was implementing Integra in 3 sites. But as we speak, through an EU-funded project and the initiatives from the government, the integration model has been rolled out to 15 sites in 3 districts in Malawi through an integration project that is coordinated by UNFPA. And with the leadership of the Ministry of Health, this is influencing the policies and guidelines at ministry level. The system is strengthening. At the moment, there is a review of the M&E system to be able to ensure that the information that is collected from the integrated services indeed then informs the health management information system and is captured for further planning. A key example here is the review of the sexual reproductive health strategy, which now supports integration, and most of the findings from the rapid assessment exercise that was undertaken have been captured in this document and incorporated in the national policy. Guidelines for provision of services, because we all agree that if you're providing family planning, counseling, and VCT separately, a client would have to spend probably an hour if you combine the 2. But then if you have to counsel that client, then we have agreed guidelines that we can then be able to use to shorten the time that the client spends. And this is what is happening in Malawi now, the review of the guidelines and training modules. And then I go back to my question. Is this benefiting where you started? And clearly in Malawi, Integra is now a beneficiary of the process, where we are able to provide counseling and testing, family planning in the same room, and a clinical officer can be able to initiate a client on ART. So evidently there is task shifting, there is integrated service delivery within the same room from what started as a small project. The message, as I was speaking to my colleagues from Malawi today, is for them, these 3 have been key to their success. 1, it is not about money. If anything, integration happens at facility level. Between the client and the provider, there is always integration. So resources is not a key barrier to integration. It can happen. For them, they have seen that in a resource-constrained setting, integration can take place. 2, provider attitudes are critical. Whenever you talk integration, and in their case, you talk integration, the provider mindset is increased workload. And probably there should be better terms, better remuneration. But with a clear understanding and influence on how we do our staffing in facilities, that is critical. And then I think one of them, the executive director of the Family Planning Association, told me for him the favorite is community sensitization. Because if demand is created among the community, and if awareness is created and communities demand integrated services, then that is the support you need for integration to take place. And he was citing an example of one of the districts where now the EU-funded project is being implemented, and when they went out there, sensitized the community from what they thought that was going to be the most difficult site to deal with. Today, that is one of their leading sites. So ladies and gentlemen, the small projects we're implementing can be the stimulus, can be the catalyst of the policy change. So let's not look at policy as an impediment to what we do, but let's look at the programs that we implement as the catalyst of change to policy. It's been proved. Integrate has done it in Malawi, and we are rolling it out with partnerships with our colleagues. You can do it. Thank you.
Thank you very much, and Lawrence, especially for your message for the need to develop synergies between programs and to harmonize